Hello. From time to time, I'm referred some very interesting and unusual cases that have nothing to do with glaucoma. These vary from cyclodialysis clefts to patients with thin sclera, but the patient I'm going to present here was particularly interesting because it was a case of a Carlevale haptic erosion that had been patched several times and was threatening to re-erode again. The challenge I faced with this case was that I wasn't sure that I could do any better than the previous surgeon, so I had to think very carefully about what was causing an erosion and how it could be prevented from happening again. Hi, in this video I'm going to describe how I approached the repair of a rather unusual Carlevale intraocular lens haptic erosion. This patient had a premium IOL replaced with a monofocal due to dissatisfaction with the visual outcome. Subsequently, the retina detached, requiring vitrectomy with a Yamane type IOL fixation. The Yamane IOL then dislocated and was replaced with a Carlevale IOL. The temporal haptic of the Carlevale IOL has subsequently eroded through conjunctiva and been patched on 4 separate occasions, and looks as if it's about to erode again, despite having been patched multiple times, even with donor cornea. As this is the 4th IOL in this eye and the patient is pleased with the vision, a further IOL exchange is not desirable. On the other hand, the nasal haptic has been fine so far. So how do I prevent this haptic from eroding again? I wasn't sure exactly how to prevent further erosion, but the first step was to explore and assess. I believe that this temporal conjunctiva has been opened 6 previous times, so careful dissection is required. The area around the haptic is gently deepithelialized. The conjunctiva is very tight from multiple previous operations and will need to be mobilized extensively for later closure. This buttonhole is likely to be the least of my problems when attempting closure later. Why has this haptic eroded repetitively, while this one is not? This haptic seems almost flush with the scleral surface. While this haptic is clearly sitting proud above the scleral surface. An obvious approach is to try and recess the proud haptic into sclera. I attempt to achieve this by grooving the sclera with a blade under the haptic. Obviously, this will only be feasible if the underlying sclera is of adequate thickness. Cautery is then applied inside the groove to shrink the tissue. These actions are performed repetitively until the haptic is adequately recessed in sclera. A 9/0 nylon mattress is then used to compress the haptic into the groove to render it as flush as possible with sclera. Although most of the haptic is now recessed, the superior end is still sitting proud, so further grooving is required. The end of the haptic now appears to be better recessed. The next step is to cut a corneoscleral patch to cover the haptic. To cover the haptic adequately, the patch must be as close to the limbus as possible. To avoid a large step at the limbal edge of the patch, the anterior edge will be buried in a peripheral corneal groove. Persistence is required as the groove needs to accommodate the anterior edge of the corneoscleral patch graft. To minimize the risk of yet another haptic erosion, the ocular surface over the haptic must be as smooth as possible. The front edge of the patch is sutured with 10-0 nylon in a manner that pulls it into the groove. Fibrin glue is applied underneath the patch to stabilize it. Additionally, sutures are added to compress the back of the patch against the patient's sclera. Because this is the fourth IOL in this eye and it has eroded so often, I'm using belt and braces techniques to prevent further erosion. Further conjunctival mobilization is attempted before closure, but it will not be enough. Because there has been so much previous surgery, a conjunctival autograft will be required for closure. But because of the amount of previous surgery, there's very little mobile conjunctiva available for autografting. Due to this limited availability of conjunctiva, the defect is carefully measured and minimized. The conjunctiva to be harvested from the inferior fornix is then measured and marked with cautery. When patching erosions, I would often incorporate a thick layer of tenons when harvesting the autograft. In this case, due to a shortage of tissue in the inferior fornix, I largely only harvested conjunctiva for the autograft. The autograft is then transferred to the recipient site, taking care to maintain the orientation, i.e. keeping the epithelial side up. The autograft is then anchored with a blob of fibrin glue before suturing in place. The glue prevents the autograft from sliding around or rolling up while it is being sutured. The autograft is then sutured in place with a locked continuous 10-0 suture, in this case nylon. The locked continuous suture is tied off intermittently. The conjunctiva is also secured tightly at the limbus. Four weeks after surgery, the ocular surface is still settling, and the conjunctival sutures are still in place. The haptic is still well covered, and although these are early days, so far there's no hint that the haptic will erode again. Thank you for watching. I hope you find this useful. So, I hope you find this video interesting. We're only 1 month after surgery, so there's still some time to go, and it'll be interesting to see how the patient does. But you can see the principles that I used to try and minimize the chance of re-erosion, and I hope you find these useful and interesting. Thank you for watching.